be presented by Dr. Firas Al-Sibai. Okay, Dr. Sibai, you can start now.
Good morning, everyone. It's 8 o'clock. Probably I will wait, one more or 2 more minutes in case somebody wants to come.
Okay.
Good morning, everybody. It is 8:02. I think it's a good time to start. I'm glad to have you all here. This is Muhammad Firas Al-Sibai, consultant histopathologist. I'm presenting to you today nasal mass and sinusitis, rule of intraoperative frozen section consultation. Our patient is a 36-year-old male with no significant past medical history, presented with headache, blurred vision for the last 2 weeks, and white-green nasal discharge. Radiology imaging showed extensive fungal sinusitis with intracranial orbital and facial extension. As you may want to see here, there is intracranial orbital facial extension on the left side. And this is another picture. A sample was sent for intraoperative frozen section consultation to rule out malignancy and to assess adequate sampling of the lesion. This picture shows a slide from frozen sections that was submitted from this patient. You may want to see diffuse infiltration by chronic inflammatory cells, and there are 2 multinucleated giant cells in the field. There was no malignant tumor in the frozen section tissue that was submitted, and the diagnosis was respiratory tract mucosa and submucosa with chronic inflammation and multinucleated giant cells, and no evidence of malignancy. The formalin fixed and paraffin embedded permanent sections show the same thing. There are numerous chronic inflammatory cells and multiple multinucleated giant cells. However, in this permanent section, you may want to see here that one of the multinucleated giant cells has fungal microorganisms inside it. And silver stain was performed, and we can see here fungal microorganisms, septated fungal microorganisms with acute angle branching. When it comes to tissue sections, the differential diagnosis in general for fungal microorganisms include Cryptococcus, histoplasmosis, plastomycosis, coccidio, and other things, in addition to aspergillosis, mucor, and candida. And for our case, the most important thing is the aspergillosis, mucor, and candida. The aspergillosis is a hyphae septated microorganisms that's showing 45-degree angle branching. However, the mycore, in contrast, has no septation, and the hyphae is branching at 90 degrees. The candida, on the other hand, has spores and pseudohyphae. So these are three important differential diagnoses for our case. The final diagnosis came from microbiology culture and shows Aspergillosis species. I want to emphasize that for histology diagnosis of fungus, we can suggest the species, but the gold standard for diagnosis is microbiology culture. So I want to take this opportunity, after I presented to you a case of sinusitis and nasal mass, I want to take this opportunity to talk about intraoperative frozen section consultation. The intraoperative frozen section consultation is an accurate diagnosis procedure for fast and rapid histologic evaluation of tissue specimen during surgery. Frozen section helps surgeon to choose the best management and therapy option for the patient. Frozen section turnaround time no more than 20 minutes in the ideal situation. That's in contrast to the routine paraffin embedded tissue that takes at least 13 hours for processing and fixation. Frozen section is a stat procedure. It takes priority over all other activities in the laboratory. The intraoperative consultations fall into two categories. The first one is non-microscopic consultation, I mean a gross examination of the specimen, where pathologists walk into the OR and open the specimen for the surgeon. This provides the surgeon with real-time information on tissue margins and the anatomic extent of disease process. In addition, this will facilitate the triage of fresh tissue for ancillary diagnosis studies or research protocol. The other category for intraoperative consultation is microscopic consultation, which is doing a frozen section. The indication for frozen section is establishing a tissue diagnosis to tell the surgeon if there is malignancy or a benign tumor. This will guide intraoperative management of surgery. The other indication is identifying metastatic disease, such as lymph node metastasis. When we have a breast cancer, the surgeon wants to know if there is metastasis into a sentinel lymph node. When they are doing a Whipple procedure and pancreatectomy, they want to make sure that the lymph nodes are negative before they start with the procedure. The other indication is to assess surgical margins or extent of disease. When we have a skin squamous cell carcinoma or basal cell carcinoma, the plastic surgeon sends us the sample and asks us if the sample or margins are free of malignancy. And that's where we assess margins. Other indications is tissue identifications. This to confirm the presence of parathyroid tissue in parathyroidectomy procedure. One more indication is establish that sufficient diagnosis tissue has been obtained. And the last one I want to tell is determine the nature of lesion that may need ancillary testing and special media, such as RPMI for flow cytometry in case that we are suspecting presence of lymphoma. The frozen section procedure is a teamwork. It requires collaboration of multiple departments, collaboration of histopathology, radiology, surgery, and nursing team. The indication for consultation has to be known for us, clinical history, radiologic findings, and intraoperative observations. Information from surgeons, such as a specimen origin and specimen orientation. When we get the specimen, we place it on the grossing bench, and gross examination is the first step in giving right and correct diagnosis for the frozen section. And histologic features for the H&E stain slides is the most crucial and important step that gives us the final answer for the frozen section consultation. Frozen section processing steps. Instead of I talk about the steps, I show you pictures of these steps. This is a case that came a couple of days ago on Tuesday. This is a 24-year-old female who was newly married and had a pelvic pain and found to have an ovarian cyst. So we received the cyst from the OR along with other fragments of tissue. We received the tissue fresh, no formalin fixation. It's very important not to place the tissue that's intended for frozen section, not to place it in formalin and send it fresh directly to the histology lab. This is a closer picture. You can see the cyst is already opened by the surgeon, and we can see multiple tissue fragments, probably necrotic, mainly fragments, and the cyst show some fragments inside the cyst wall. We sampled the cyst, and in this section, you can see the serosal surface here and the internal surface of the cyst. So, and we will embed this piece of tissue like this placement, so that we can see the tumor that's coming from inside the cyst all the way to the serosal surface. We place the tissue inside a metal block, and we add an OCT liquid. And this is another fragment or another tissue that came along with the cyst. Those are the multiple fragments that they came along with the cyst. Now we use liquid nitrogen to freeze the tissue. We add more OCT, and we use a chalk to put it on the tissue. We choose chalk, so there we have small, medium, and large chalks, depends on the size of tissue that we are fixing and freezing. We adding more liquid nitrogen. It's almost ready. And now we have the block. This is an intra and intercellular water that is freezing to produce hard matrix, enabling slicing of the tissue. We take this block and we take it to a cryostat. This is a cryostat machine. The screen of the cryostat is showing us that the temperature is minus 19 Celsius, and the thickness of the tissue that we're gonna cut is 5 microns. We place the chalk inside the cryostat and we start trimming the tissue. Finally, we got a nice thin intact section. It is about 5 micron thickness. We pick it up by a glass slide. We place it in alcohol, then we stain it with H&E, hematoxylin, and EOS. Just I want to tell that tissue that cannot be frozen are bone and fat, because bone need decalcifications. It cannot be cut by regular knife. It has to be decaled for 1 or 2 days before processing. The other tissue that cannot be done by frozen section is fat, because it is very soft and friable. It will not, it's almost impossible to cut a tissue that's only fat. So after we get to the slide, we look under microscope and we make diagnosis, then we deliver the diagnosis to the OR. Diagnosis could be written and sent to the OR, or could be verbally communicated and transmitted to the medical staff in the operating room. The pathologist should first confirm with the recipient of the information the following points. We have to have 2 identifiers of the patient, record number or date of birth. We have to have a name of medical staff who is receiving the result, and we tell them the kind of specimen that we are giving a frozen section diagnosis on. Then the last step, read back the diagnosis. We ask the medical staff in the OR to repeat the diagnosis for us to make sure that there is no misunderstanding or no misinformation that has been delivered to the medical staff in the OR. This is a crucial decision that is going to be done to the patients. Like everything in life, there are limitations for frozen section, and there are multiple causes of errors: sampling error, interpretation error, and technical errors. The sampling errors, there are like 4 reasons for sampling errors. First one is poor sampling of tissue by surgeons. So instead of sending sentinel lymph node from axillary lymph nodes, sometimes they are like firm fibrous tissue that we receive. There is no lymphoid tissue or lymph node tissue in the specimen that is received. So that's because of sampling error. The other thing is error done by pathologists, which is poor selection of the tissue by pathologists after grossing the specimen on the grossing bench. Other thing for sampling errors is extensive tumor degenerations and necrosis when we freeze the tissue and there's only necrosis or degeneration in the tissue that has been chosen for frozen section by pathologists. One more thing is poor assessment of capsular or vascular invasion in endocrine organs such as thyroid. It's very hard to assess that under a microscope in frozen section slides, and we need to assess multiple sections, and that's the reason why it's a sampling error sometimes. Interpretation errors, tumors that are difficult to diagnose, such as signet ring cell carcinoma in diffuse gastrectomy specimen, or lobular carcinoma in breast cancer. These are kind of tumors when they metastasize to lymph node. If there are few cells only, it is hard to find them under the capsule in the lymph node. They are very sneaky cells, hard to find. So that's a cause of interpretation error. And the other thing is tumor heterogeneity, such as soft tissue sarcoma, mixed tumors, and biphasic tumors, such as germ cell tumors that has multiple components, such as embryonal carcinoma, choriocarcinoma, and yolk sac carcinoma. One more thing for interpretation errors is difficulty to assess chronic pancreatitis versus pancreatic adenocarcinoma. One more thing is difficult to assess ganglion cells in Hirschsprung disease. All these difficulties can give us a false negative in the interpretation of the frozen section sample. The technical problems or technical errors could be secondary to freezing artifact or xylene artifact, where we have holes or shattering in the tissue because of freezing artifacts, improper cover slipping of slides, water presence in the xylene solution which cause cloudy sections and fuzzy picture under microscope. The poor quality preparation is because of thick sections, folding of tissue, or air bubbles. We can group the limitations and errors into 4 groups: change in category from benign to malignancy, or vice versa, a change within the same category, the change in the histologic type of malignancy, such as adenocarcinoma to squamous cell carcinoma, or vice versa, a change in the status of resection margin from false positive or false negative for malignancy, and change in lymph node status for false positive or false negative for malignancy. However, frozen section could be misused sometimes, and we have to make sure that we educate our colleagues to make sure that we are doing the frozen section under appropriate indications. Sometimes the inappropriate use of a frozen section is because of compensate of inadequate preoperative evaluation. If we have a mass, if we have breast mass and or lung mass, and this mass is accessible by core biopsy or FNA, we have to make the diagnosis beforehand, before we start the surgery. We don't keep making the diagnosis to the frozen section, because we can save the patient's time and a lot of health problems that could happen during the long period of the operation. The other inappropriate using of frozen section is to satisfy surgeons' curiosity. And one more thing is it's sometimes used as a mechanism to deliver diagnosis more quickly to the patient or to the patient's family and tell them the diagnosis is benign or malignant. We encourage our colleagues to just wait until we get the final answer from the permanent sections that will give us best answer and best subcategorization and subtyping of the malignancy. Other contraindications or things that are discouraged using for frozen section when further surgery or treatment is not based on the result of a frozen section. If we have a small lesions, it's highly recommended not to send it for frozen section because of fixation artifact or losing of the tissue, such as a pigmented lesion of the skin or a small tissue from brain biopsy. We try to save it for permanent so we can do additional test on it, or we can give a better diagnosis and better subclassifications of the tumor. Low sensitivity or specificity when looking for capsular invasion and follicular lesion of thyroid also might be relatively contraindication for cases with infectious disease such as TB. Fresh tissue may be expose the pathologist and the technician to the infection, and also we need to disinfect the cryostat for 24 hours, so we cancel other frozen sections for that reason. Now let's come to the accuracy of a frozen section. How accurate is a frozen section? Is it worth to do a frozen section? Yes, frozen section is a technique that's very reliable in good hands. Most centers report an accuracy rate from 92% to 98% depending on the cases studied and site of tumor that's been submitted for frozen section. A large center in Mayo Clinic has issued an article about reviewing a 24,000 frozen section over 1 year, and they showed 97% accuracy. Same result we got from another publications from Millage, 97% of accuracy. In ovarian tumors, the accuracy rate is almost 98% for malignant tumors. However, it drops to 78% for borderline tumors, and the cause is known. These are borderline tumors that need a lot of sections to diagnose, and not only one section as its situation in a frozen section procedure. Regular self-audits of a frozen section service are important, so surgeons and pathologists are aware of their performance. The pooled data across hundreds of institutions showed that the accurate diagnosis is generally more than 95%, and the discordance rate with the final diagnosis is up to 2%, and the deferral rate for permanent section diagnosis is up to 4%. Accuracy of a frozen section is dependent on the anatomic site, as some anatomic site have more percentage of having limitation of assessing the tumor, such as ovarian masses and brain tumors. This study was done in 2016-2017, discordance between intraoperative consultation and frozen section and final diagnosis. They studied more than 1,000 frozen sections over a period of 6 months. They found a deferral rate 2% and discrepancy rate 4.6%. The discrepancy rate was because of processing errors and interpretation errors. The processing errors was more 54%, and the interpretation errors was 46%. The processing errors, as we indicated before, was like gross sampling, histologic sampling, and surgical sampling, and interpretation errors was undercall, overcall, or misclassifications of tumor. So with this slide, I come to the end of my presentation, and I will show you the forms that are being used at the Prince Sultan Military Medical City. And I want you to be familiar with these forms, and the OR staff have to be familiar with these forms, so we can have better communications and better information from the other part of the team. So this first form is a frozen section booking. It shows the first one shows the patient's name, department, consultation, file number. So we have patient information, frozen section site, and frozen section indication. Is it to rule out malignancy, to determine the nature of the tissue, to resect for adequate margin or assess for adequate margin, lymph node metastasis. And we want to see to know the location, which OR, and the phone number. So this is a frozen section booking, and we ask our colleagues to book for frozen section a day before at least, so we know that there's a frozen section coming, and we prepare ourselves, our team and our lab, in case there are two frozen sections coming at the same time, so we can have more people ready for the coming specimens. The other form is a frozen section request form. This is when the OR sends the specimen. It comes along with the patient's specimen. It has all the patient's information, clinical information, and you can see here we have the gross and diagnosis section. So we write our diagnosis, and it's reported by Dr. So-and-so and received by Dr. So-and-so at the time of receiving of the specimen. And the last form is for QA and turnaround time. This form, as you may want to see here, there's receiving number of blocks that we have prepared, source of specimen, and type of procedure that we have done for frozen section. Is it touch print, smears, sections, gross only, and the diagnosis we have made, is it benign, malignant, indeterminate, and reporting delivered to the information delivered to the patient, OR, to the surgeon. Make sure that we confirm the file number, patient's name, we confirm the specimen type, and read back of the diagnosis. Also, we assess for the quality of the slides. Are they satisfactory or unsatisfactory for evaluation? Is there any artifact about staining, cutting, freezing, orientation? At the end also, we give the number of blocks and turnaround time. Turnaround time should be, in ideal situation, less than 20 minutes. However, it could be more than 20 minutes in cases of multiple specimens or multiple sections have been taken from one large case, or multiple frozen sections that came at the same time. So these are important information that we need to have from our colleagues. The Form 1 and Form 2, and this current form that you have on the screen, this is a very important form for us to do a QA and to monitor the progress of improving in our lab, and relying the information to our colleagues in the operating room. So in summary, I presented to you a case of 36-year-old patient with extensive fungal sinusitis and intracranial orbital and facial extension of the lesion. I presented to you intraoperative frozen section consultation, importance, indications, limitations, contraindications, accuracy, and QA measurements. This is the end of my presentation. I would like to thank you and thank everybody who has attended the lecture. These are my references. And a special thanks to Dr. Abdulrahman Al-Qahtani, who helped a lot with taking the photos and putting the slides together. Thank you very much. I'm open here for questions. And before I finish the presentation, there is a survey that's going to pop up on the screen. Please complete the survey so we can get a feedback. Thank you.
Thank you, Dr. Firas. Any questions from the audience? I have actually one question, if you don't mind. Do you recommend doing frozen section for non-encapsulated lesions in thyroid? Like you talk about like encapsulation and vascular invasion and the capsular invasion. What about non-encapsulated lesions in thyroid? Do you recommend doing frozen on it?
Yes, as you said, it is not recommended to do a frozen section consultation for encapsulated lesions, as these lesions need to be thoroughly sampled, section sampled, and examined. However, other neoplasm, such as non-encapsulated lesions, such as papillary thyroid carcinoma, medullary carcinoma, can be done on a frozen section. However, we highly encourage other, the clinicians to make sure that they tried, the best to get a sample by FNA, because thyroid is very accessible organ by FNA. So if they can do an FNA beforehand, before going to surgery, to make the diagnosis. However, for some reason, if the frozen section, if the FNA was not successful or was not giving the diagnosis that was expected, I think that a frozen section, yes, can be done on thyroid neoplasm, such as papillary thyroid carcinoma, giving a note that papillary thyroid carcinoma features are usually seen after fixation artifacts such as clearing. But if we have a papillary architecture, if we have grooves, inclusions, this will help us make the diagnosis of thyroid tumors. But also, I want to comment on sending a lymph node, a cervical lymph node that could be sent to assist metastasis from thyroid neoplasm. Yes, this is a definite indication for frozen section, cervical lymph node with patient of thyroid neoplasm. Any other questions?
Thank you very much, Dr. Sibai.
So the presentation had come to end. I hope I have delivered the proper information to you. And please, everybody, fill out the survey form that's gonna pop up. Thank you very much, and you have a good day.
Thank you, Dr. Firas. Thank you very much. It was a nice lecture. Thank you, everybody. And good.